Hello friends, this is a case of two-port cholecystectomy. We will use only one umbilical port and only 5 epigastric port, and we will use the Stryker mini alligator to perform this surgery. So, we are putting varus needle over the inferior crease of umbilicus, and the insufflation is started with the varus needle. So, here we are doing irrigation, suction and hanging drop test. And then the pneumoperitoneum will start. So, we are using the preset pressure 15 and slowly actual pressure will reach to preset pressure and flow rate is 1 liter per minute. So, we can see gradual homogeneous distension and waiting for pneumoperitoneum to establish. So, this is a only two-port cholecystectomy. We will put one 10 mm. One 10 mm is necessary because removal of the gallbladder will be doing by the umbilicus, and we will put one only epigastric port 5 millimeter for the sealing of the cystic duct and cystic artery. For the traction of the gallbladder, we will use the Stryker mini alligator that will hold the fundus. So, pneumoperitoneum is done. Now, we will enlarge the incision to 11 mm, that is a smiling incision. Dilating the obliterated vitreointestinal tract, and then the 10 mm port will be introduced. So, now the telescope will be introduced, and now we will introduce the epigastric port, and that will be only 5 mm. So, this is the GP sternum. Just below the GP sternum, only 5 millimeter incision will be given. When this is the 5 mm, port will be used for dissection, sealing of the cystic duct and cystic artery. And now we will give one a small stab wound over the mid clavicular line, just below the costal margin, for the Stryker mini alligator. So, this is diagnostic. So, basically this third one is not a port, it is a only mini alligator. So, it is just a stab wound without any port. You can put the alligator inside, and that will be the left hand to giving anterolateral or anteromedial traction. Now, head is up and right is up, patient is tilted towards the left side, and now the surgery will start. So, we are not using third and fourth port, we are using a Stryker mini alligator. So, this is the outer view. Now, inner view we will see that this Stryker mini alligator will catch the middle of the body of the gallbladder, because we have to take both the action. This has a atraumatic grasper and it is available by the many company, and this is very innovative instrument. You don't need any port, directly you can go and you can perform the surgery. It has a lock also, and there is one elevation angle connector, and then you can perform this surgery. So, these are the mini lap instrument which you can use for the third port. It has a very less trauma and it can hold atraumatically any structure which you want. So, the first step is adhesiolysis, and we will remove all the adhesions. and after that we will do the posterior peritoneal dissection, and a striker will be relocated little down so that it can optimize the traction. We can see duodenum is pushed down, and we can see this is the rovier sulcus. Here little bit adhesion, this is CBD. So these adhesions will be stripped down. And now this is the posterior peritoneal dissection above the rovier sulcus is started. With the Teflon jaw of harmonic, you can give little traction so that gallbladder will not puncture and peritoneum can be easily separated up to 1/3 of the gallbladder. Now this is the anterior peritoneal enlargement so that posterior window will be created. Then we can see inferior surface of the liver is visible and posterior window is created. We can put the ICG on, you can see this is CBD, and this is a very small cystic duct in this patient. So we will do little more the dissection of the cystic plate. And up to 1/3 of the gallbladder posterior peritoneum is separating. Now we will take a, this is the artery below, we will take a Maryland and conform the posterior window by opening the jaw of the Maryland, and inferior surface of the liver should be clearly visible. Now this is the separation of cystic duct with the cystic artery, and we can see lymph node of Lund is visible, and slowly dissection will be carried out in between the artery and duct with the blunt dissection with the Maryland. These are just the fibrous tissue which you can break. We do not have any grasper to hold the Hartmann pouch. So, this striker mini alligator is just holding the body of the gallbladder, and then we will turn the ICG mode on. Here this is the artery, this one is artery, and we can see a small lymph node is also visible. So, again Maryland is required. This patient has a very short cystic duct, and tenting of CBD is visible. So we have to be very careful. In the short cystic duct, you should try to be more careful. So this is a dissection in between the artery and duct. So this is cystic artery. And a window is creating between the artery and duct. This is the ICG mode, and we can see short cystic duct. Behind is the duct. And now this is the artery. So this is the interior window, and critical view of the safety should be established. We have already injected 2.5 milligram the ICG 45 minutes before the surgery. So before doing anything, we will turn the ICG mode on, and here this is the artery is getting sealed by the ligature. So tip of the ligature should be clearly taking only artery, nothing except artery. You can relax the gallbladder a little bit so that sealing will be better. And artery is cut. After that, we will reconfirm the duct and posterior window. And inferior surface of the, and this is the ICG, which is clear cut showing the CBD. This is the common hepatic duct, and here the cystic artery is anterior to the common hepatic duct. Right hepatic artery is anterior to the common hepatic duct. That's why it was taken first, and little bit more dissection of the posterior peritoneum will be carried out to make it confirm that there is no any tented CBD. The cystic plate is enlarged. So now this is better that you should completely free the posterior structure to make it sure that there is no any structure, no any double cystic artery, no any duct of Lasca. And now we will use ligature again to seal the duct. This is nipple effect. Once you will relax, you can see it is going towards the gallbladder, and then you can seal the duct. This is a short cystic duct. So again, relaxed while sealing. It should not be under tension. So it is done. Now again ICG has confirmed that CBD is clearly visible, common hepatic duct is clearly visible, and now the gallbladder will be separated from liver. So this is a clipless cholecystectomy, and we can see sealing of the gallbladder, which is not leaking, that means it is fully sealed, and a good areolar plane should be maintained, and the remaining gallbladder will be separated from liver. Anterolateral anteromedial traction should be given. Teflon jaw again we should keep towards the gallbladder, so there should not be any puncture. And slowly it is getting separated. Compared to the simple cholecystectomy, here the size of the cystic duct was little smaller. So, that is why compared to the other surgery it was little more difficult, but you can easily perform, and harmonic or ligate sure both you can use for clipless cholecystectomy. So, now this is over, just the last part of the fundus attachment of the gallbladder liver is there, that is also getting separated. Now, because we have only one 10 mm that is in umbilicus, so we will take the gallbladder out through the umbilicus, and for that you need a 5 mm telescope, and claw forceps will be introduced through the umbilicus and it will be pulled out. So, thank you very much for watching this video. This was just a 2-port simple clipless cholecystectomy. Have a nice day.